Hello, my name is Haley Miner. I am the nursing manager here at the St. Vincent Stress Center over our adult, youth, and PRN pool associates.
And I'm Erin Chapman. I'm the nursing educator here at the Stress Center as well.
So I'm going to start out today. We're going to talk a little bit about what inpatient care for psychiatric patients looks like, means, how they get here, how they get out of here kind of thing. So here at the Stress Center, just to give you a little bit of an overview, we have 5 inpatient units. We also have an extensive outpatient program in day school and such, but right now we're just going to focus more on our inpatient services. So we have 3 adult units. We have a 20-bed unit, which we kind of think of as our general patient population. So patients on that unit often are experiencing depression, anxiety, suicidal ideation, those kind of things. On our dual diagnosis unit, we have patients that have both a mental health diagnosis as well as a chemical dependency or addiction type diagnosis as well. And then we have an 8-bed unit, which we think of as kind of our critical care space. So it's much smaller, much less stimuli, but it's really for those patients who are the most critically ill. So patients often with schizophrenia, maybe experiencing mania or psychosis are on that unit. So you might be wondering, how do you get on one of our units? Maybe because you're interested, or maybe just because you're curious. So to be admitted to an inpatient locked psychiatric unit, you have to be kind of falling into one of 3 categories, sometimes multiple of the 3 categories, and that is a danger to yourself, a danger to others, or gravely disabled. The most confusing one, I think, is probably gravely disabled. So what does that even mean? So gravely disabled is you're not able to care for yourself as far as ADLs, or you're not able to really get around in the world because you're really, you're so sick that you can't communicate appropriately with others and things like that. And so any of those 3 categories is kind of defined as admission criteria for one of our units. But there's multiple ways that you can kind of get into our building to even be assessed for those things. The majority of our patients, probably contrary to popular belief, come in on their own. So they walk right in our front door and ask for an assessment. Probably about like 94% of our patients actually walk in or in involuntary status. We do have a small patient population that don't come in on their own, aren't real happy to be here, or don't think they need help. And so when those patients come in, sometimes they're brought in by the police. Sometimes, unfortunately, they're tricked by family or friends that are just really concerned. And sometimes they go to our emergency room for something unrelated, and the emergency room has them brought over for assessment. And when that happens, and in fact they do need admission, then that is considered an involuntary admission. The patient kind of loses the ability to consent at that time, and they're placed on a 72-hour hold. Anything about any of that I'm missing?
I don't think so.
Okay. Well, would you mind talking a little bit about what treatment looks like?
And to piggyback on what Haley said, the reason our units are divided the way they are is due to our programming. So really, on our dual unit, when we have folks with that mental health diagnosis and that substance use piece, their programming, so the groups that they meet in, and just being around folks dealing with the same issues, they can just relate more. And that's what the programming is going to be based on. Also, on our 20-bed unit, that programming is going to be different than 8-bed, because if you're not eating, taking care of yourself, and you're not able to communicate with others about what's going on with you because you're so ill, you're not really going to benefit from a group where you're processing a lot of different issues when we're just really trying to meet those basic needs. And so throughout the day, our patients work really, really hard when they're here with us, because you're very sick if you're having to be on a locked unit. So pretty much from the time they wake up to the time they go to bed, they have group programming all day. So it's not individual one-on-one based, so it's a group therapy. They meet with our social workers, counselors. We have pastoral care groups. Our mental health clinicians run groups, nurses, activity groups, so trying to touch on all those pieces within the short amount of time that they're here. And programming is really what patients need, and we try to jam as much as we can in a short amount of time, because there's absolutely medication changes that are made, but those medications usually take a long time to get in folks' system, so they're therapeutic, and so we really need to teach those basic coping skills when patients are here, and not just give them medications. But that's definitely a piece. I would say that since they're here with us and we can monitor them a little bit closely, we can make medication changes that they might need a little bit faster than they could in the outpatient world. And what else? What else
I think the only thing that I would add to that is with all that programming, it's so important that our patients have structure. That's one of the biggest things that they lack in their personal lives. And so kind of not only teaching them how to implement structure in their own lives, but while they're here, really keeping them distracted maybe from some of the things that are going on maybe at home or outside of here, and just really keeping them focused on themselves is a big thing. Sleep hygiene is really big. So on our schedules, we have like lights out time, which feels very much like summer camp, but really it's more just to help them get their rhythms back in.